Carrie's team was doing the hard work, as with a lot of health systems, in December of 2020. And we literally, around Christmas and New Year's of 2021, when we were starting Turquoise, we're ready at our computers to ingest all of these hospital files. So you got about 6,000 hospitals in the United States, and some health systems like Intermountain, where some of these files are condensed. But then it quickly became Easter, because we call this the world's worst Easter egg hunt. You have to go to every hospital website. And it's not just grabbing the file. A lot of folks thought these files would be simple Excel files, but as Carrie mentioned, they're massive. And so to give you an idea of scale, a lot of the provider files are like 1 to 2 gigabytes, which if you were to download Lord of the Rings and watch it, would be like downloading one version of Lord of the Rings in your computer. Carrie also mentioned that there's a new Easter egg hunt now, the payers publish files, and those come in at about 500 terabytes, and the average files are around like 1 to 10 gigabytes. And so, it means you're downloading Lord of the Rings thousands of times now. But it means that you need a team of engineers to deal with this data, to put it together, to create a picture of prices across the country. And at Turquoise, we responded to the invitation that you see in many of these rules that say, we hope third parties come in and create more user-friendly experiences with the data. And that's what we've done. We've ingested the data over the course of the last 2 years. We put it on our website for free. So if a consumer is looking to browse the cost of care, you can enter your zip code or enter the service you're looking for, view these rates. Then we do think the rest of the industry should have the data as well, to create some healthy market forces in healthcare that have never been there before. And so we've really just spun up this massive, several Lord of the Rings movie size database that covers healthcare prices across the US. And I think the biggest difference between last year and this year is you only had hospital data last year. Now with the payer data, you have all providers. So you have the primary care doc down the street, you have the imaging centers, the surgery centers, and really with all these provider types, you get a nice picture of your options as a consumer in healthcare, but a good picture of the market. So that's the background on what we're doing. One final note on the consumer piece is that the great thing about this rule in July is it does have all sites of care. And so we do have hospital data, and Turquoise is crunching some of the payer data. But here next month, we'll be launching on our consumer site, so free for everyone, non-hospital data as well. So you could go browse surgery centers unaffiliated with hospitals. You could go browse imaging centers, cardiology groups, et cetera. And so I think, like Carrie was mentioning, it's just going to take time as all these data points roll out. But in startup world, it's 2 to 3 months, like not 2 to 3 years. And so we're really excited for like the whole complete choice in the market. I give people the analogy, like I live in San Diego, and right now it's as if we have like all the nice like fine dining restaurants in San Diego are posted. And if you're really feeling like a really nice steak, those rates now thanks to the hospital rule. And now what we're seeing is all the restaurants come online, the Jack in the Box down the street. And so you see this full like competition happening in the market. And so that's going to roll out over the next, really the rest of this quarter and early into Q1. For employers, what it means is this data was very big, like we mentioned, and there's tons of innovators, Turquoise is just one of them, that are distilling this data to be very small so that you can apply some filters and get just a slice that matters to the region that your headquarters is located in, or just the service categories that are really plaguing your self-insured spend, high cost drugs, orthopedics. And you can go drill in and say, hey, if open enrollment's coming up, should we stick with the same carrier in this region? First of all, you could do sort of a carrier-based comparison based on really the discounts in the area available to you. And then you can also really just like look into high cost and maybe where you're not getting the same quality outcome. So, we've mentioned x-rays, you could throw in other types of imaging where, hey, if we're going to a very expensive location for imaging, and a lot of our employees are funneling to this location, and we think there's an imaging center or another hospital that can provide this imaging to those 100 employees at a more affordable rate. There's a lot of things you can do. You can, as an employer, contract directly with the provider. You can also, there are tons of vendors doing sort of incentivized kind of rebate style things for patients and say, hey, you will pay less if you go to this place and you'll have the same service, same quality. And so we'll see employers doing those things, really comparing high cost claim spend with more granularity in this data at open enrollment, assessing the different carrier options that they have, and then steering patients towards more cost-effective care. Right now, billing in healthcare is built around a coding system, essentially, that helps turn clinical events into billing codes that then translate into payment by the patient, payment by insurance companies. And right now, there's about 25,000 outpatient billing codes. To give you an idea, there's about 52 different codes for a hysterectomy, 36 codes for different types of colonoscopies. There are about 1,000 different inpatient billing codes for inpatient events. And a lot of contracts between insurance companies and hospitals have all of those billing codes, or most of them, negotiated for each individual code. Some are that complex, others are slightly simpler. What that means, though, is that granularity of billing codes, which is meant for actuaries in the industry and CFOs of hospitals to see what services they're providing, it doesn't really translate well to consumers. And so when you go on Turquoise, you are able to browse. Maybe it looks kind of familiar. And you get to just the part where you see the price, and then you see a disclaimer. And right now you can't add to cart, you can't schedule, you can't check out. That's because that billing code is just an estimate. When you go to the hospital, you may actually get another billing code or a slightly different billing code. And in the end, especially for Intermountain, because they did a great job with their files, you'll probably be billed something pretty similar. And the thing you saw in Turquoise is a good estimate, but it's not that upfront binding price. And it's also not totally clear that you're going to get exactly the service that you found on Turquoise. You may get a diagnostic colonoscopy of this type. You might get a therapeutic colonoscopy. It's kind of confusing. And so the project we were talking about, that Ryan was talking about, is how do we standardize some of these services? So with hysterectomies, maybe there's just like 2 or 3 categories. With colonoscopies, maybe there's diagnostic and therapeutic. How do you standardize some of these categories to make sense to consumers and build towards this consumer-friendly upfront price? But then the hard part is Carrie and other health systems and payers have a system built on that super granularity. And so merging this new consumer-friendly world with the rails that we say the system currently runs on is kind of difficult and requires innovation, not just from innovators like Turquoise with third parties, but from providers and payers. I want to add as well, just really quick, someone mentioned in the chat, as this data becomes better, healthcare does work slightly differently, where it won't always, when we say consumers will use this data, at Turquoise, we don't know if ultimately consumers will be the main users of the data, or more likely the referring providers, their trusted primary care doc, some advocate that is a bit savvier, does this more often. To Carrie's analogy of the car mechanic versus the restaurant, I eat at restaurants all the time. I take my car in once or twice a year. And so you do need that advocate to say, hey, I know you don't get heart surgery very often, or get a cardiac MRI very often. I'm looking up some options for you. So that's a great analogy, and just acknowledging that comment in the chat.